Hi, I'm Dr. Larry Malerba, and thanks for tuning in to All Things Homeopathy. In the last two episodes, I explained homeopathic symptom classification. Now we get to put that knowledge to use. Today I'll be talking about case taking for acute conditions. The first step, therefore, is to make sure that the problem at hand is actually an acute problem and not a chronic one. While chronic case taking requires that we investigate all aspects of a person's health on all levels, acute case taking is less intensive because your questioning is limited only to the specific details of the acute illness. An acute is any new problem that a person has not had before, one that can be expected to run its course in time. A chronic condition is one that does not go away or one that tends to recur. Examples of acutes include a viral illness, a flu, bronchitis, croup, food poisoning, a bladder infection, an insect sting, heat stroke, and injuries like a sprained ankle, a bone fracture, or a whiplash neck. In such instances, case taking should be limited to investigating the nature of the new symptoms only. It's important not to mix the two up. An attack of diarrhea in a person who has colitis isn't considered an acute as much as it is an acute flare-up of a chronic illness. Likewise, a migraine headache in a person prone to migraines is really a chronic condition. The main goal of case taking is to gather as much information as possible in order to paint an accurate picture of the problem. Without a clear description, the next step, case analysis, would just be a waste of time. That old computer science cliche, garbage in, garbage out, is very apropos here. It's necessary to have clear, detailed information before it can be analyzed. Note that this is completely different from the conventional medical goal of making a diagnosis, which involves taking various details and generalizing in order to assign a label. The aim of homeopathic case taking is to individualize, not to generalize. This is accomplished by ascertaining the unique nature of each individual case without assigning it a one-size-fits-all label. Case-taking begins by asking an open-ended question, after which the patient is allowed to talk without interruption. If the patient has a sinus infection, for example, you don't say, "Tell me about your sinus infection." That would be a leading question. "How can I help?" or "What's going on?" is a much better way to start an interview. After that, it's your job to listen, observe, and document what is said while giving the patient all the space he or she needs to describe the problem. When the patient runs out of things to say, don't assume that your job is done. Encourage the patient to tell you more by asking, "Is there anything else?" and keep repeating the question until he or she has nothing more to say. All the while, the patient's words should be documented verbatim. If he or she says, "It feels like my head's going to explode," for example, that's what you write down. Avoid the temptation to take shortcuts and don't interpret what the patient says. If someone says, "I feel like screaming," don't write down irritability as a substitute. Spontaneous expressions like this are often the most valuable. Only after the patient has nothing left to say do you then begin to ask more specific questions. And even then, it's best to keep your questions as open-ended as possible. If earlier in the interview the patient mentioned a cough but did not elaborate, you can simply say, "Tell me more about that cough." When you want someone to elaborate, an effective strategy is to simply repeat the last statement back to the patient in the form of a question. If the patient says, "My knee hurts," you say, "Your knee hurts?" Alternately, you can ask, "How do you mean?" When writing down symptoms, it's necessary to have a method by which to emphasize or to grade those symptoms. One of the oldest and most visually effective methods is underlining. One can underline a symptom anywhere from 0 to 3 times, depending upon a variety of criteria. Such criteria include the spontaneity with which a symptom is relayed, how clearly it is described, how intense it is, how frequently it occurs, the degree of discomfort that it causes, and the limitation that it imposes upon the patient. If, without you asking, the patient says, I'm so exhausted I can barely keep my eyes open, you'll want to give that at least 2, maybe 3 underlines. If you ask, have you been feeling more warm or chilly, and the person hesitates for a while and finally says, I think I've been more warm, then you probably don't want to underline that clue at all. The key is to be consistent with your grading so that you can understand your own notes when you go back to study the case. Only after the patient ceases to provide information do you then begin to ask more specific questions. In the previous 2 episodes, I discussed mentals, generals, specifics, and modalities. Here is where we put that knowledge to use. Now you can go back and fill in the details by asking more specific questions about that cough. What is the cough like? Where is it coming from? What aggravates and ameliorates it? And so on. Make sure you ask about the generals too. Remember, when taking an acute case, changes from the patient's normal baseline are most important. If a person generally has a strong thirst and is now sick but is still thirsty, that doesn't represent a change from baseline. But if the same person is now thirstless, that can be a very helpful clue. Again, it's a common mistake to ask leading questions, especially when you suspect a certain remedy may be indicated. It's natural for patients to want to give answers that they think the interviewer wants to hear. So avoid the temptation, for example, to ask if the person feels anxious when you think arsenicum may be the needed remedy. Remain objective and instead ask, how do you feel emotionally? When treating children, it's important to be thorough because much of the information you receive will be secondhand information from parents or guardians. This is when your powers of observation are particularly useful. Is the child quiet, fidgety, irritable, sleepy, talkative, pale, red, slumped in the chair, sitting on mom's lap, and so on? These are all things that can be picked up by an observant eye and documented on paper. To be realistic, most people are not used to observing their own symptom patterns in such detail. We have conventional medicine to thank for that. It often requires patience and a willingness to educate patients about how to report symptoms. Given some dedication, study, and repetition, your case-taking will surely improve in time. Even after 30 years of practice, I still occasionally learn a new trick that adds to my case-taking skills. Thanks for listening. I hope these videos are clear and informative. My goal is to make quality homeopathic education available to all who are interested. If you haven't already done so, please subscribe to the ATH YouTube channel, and please join me again for the next episode of All Things Homeopathy.